All right. Good afternoon, everyone. Welcome to this online event on the occasion of the launch of our report on urban health equity in urban India and a panel discussion on reimagining urban healthcare in our cities. We would have loved to hold this event on our campus, but we do realize that many people are unable to travel yet due to various constraints. So we are holding this event online. We hope to have a very interesting and insightful discussion in a few minutes. Let me start by just saying a few words. As many of you are aware, the purpose of Azim Premji University is to contribute to a just, equitable, humane, and sustainable society. And as we have also seen, the pandemic has brought to the fore the tremendous inequities in healthcare for disadvantaged groups in rural and urban India. This report, this comprehensive report on the state of urban health in India, highlights some key gaps in the health system which lead to these inequities that we see in health access for the urban poor. But this report also points us to some hope. It suggests steps that can be taken to fill these gaps, to make good quality healthcare a reality for everyone. This report, as you will see, is a result of collaboration between the public health team at the university and organizations which work on these issues on the ground. We hope that the report is useful for practitioners, researchers, government bodies, communities, and advocacy groups in their work. Before I turn over and to my colleague to start the event, I also would like to use this opportunity to share some exciting news. We are setting up Azim Premji University in Bhopal, from where we will offer a master's program in public health. This will begin in July 2023, so not so far away. We plan to bring the same kind of social justice and practice orientation to a master's program in public health as we have brought to this report. So with this, thanks for joining us. We look forward to an interesting and insightful panel discussion on reimagining urban healthcare in our cities. Let me hand over the forum to Rima Mishra, who anchored the development of the report and will walk us through some of the main findings from the work.
Thank you, Richa. So what I'll do is that I'll kind of very briefly take you through the report. Uh, and this basically, I present it on behalf of the entire writing team as well as the contributors from our partner organizations. Um, why this report? And I think it's important to set the kind of the context for this. And there are three kind of components to this context. One is that all of us are, part of growing rapidly urbanizing India. Not only that we're talking about cities expanding, big cities expanding, but also the number of small towns also is increasing. But this growth actually is not commensurate with provision of basic services, including health and healthcare. And that's a concern which needs to be really addressed. And second, related to that, as Richa said, and all of us kind of witnessed it, the COVID-19 pandemic was actually a cruel reminder, of the kinds of inequalities broadly and inequalities in health that we actually witnessed. Not something new, but it just that made it distinctly visible. It also reminded us that why the rural urban comparisons that we have been doing it for a long time actually really don't do justice in understanding the kind of inequalities within and among urban areas itself. And the third, related to that context is that, what do we know about what do the, health systems, urban health systems look like? Is there a clear architecture that we are talking about, the way that, that's there in the rural areas? Who is actually responsible and accountable for providing healthcare in urban areas? And we're asking this question also all the more because of course, policy attention to urban health has been relatively recent. But in 2013, when the National Urban Health Mission came, was rolled out, came up with a clear architecture, at least proposing this architecture, and we are now more than 8 years into this mission. Where are we and what does it look like? Relatively, there is a paucity of understanding in terms of the comprehensive understanding of urban healthcare, and that actually drove us to attempting writing this report. So, what is the focus of the report? We actually had three sets of questions. One is that we're talking about increasing acknowledgement, that's what we actually witnessed during the pandemic as well. Is that the poor and the vulnerable groups actually bear a disproportionate burden of health risks, and outcomes. So, but who are these urban poor, and how do we understand their health vulnerabilities? That's the first question. The second is this: so how is urban healthcare organized? What do the health system governance actually look like, and how does it impact access to affordable and quality healthcare? And the third, having unpacked all these, what actions are needed and by whom towards addressing, urban health inequity? So, how did he go about it? We actually, and this is important actually to talk about, is that we needed a very granular understanding of what we are talking about, the nature of vulnerabilities. What do the different cities and towns the healthcare provision actually looks like? So we actually sought detailed inputs and through various ways, through consultations, through key informant interviews, as well as many of these organizations actually have you will see in the report that they have got short write-ups on their work as well. So detailed inputs from different organizations as well as networks on urban health across different geographies. They're working with different communities in different parts of India. We also, of course, did a descriptive analysis of large data sets, particularly the National Family and Health Surveys, as well as the Census of India. In order to also understand the urban health system governance, we focused on trying for a deeper understanding of four different cities and towns. For that, we of course draw all information from whatever that was available on the government websites, but also it was validated by select health officials in these particular cities and towns. And of course, we drew on our own experiences, the Azim Premji Foundation during the COVID-19 pandemic, specifically from Bangalore. So, what is it that we found? And some of the kind of findings I really touched on it, and all of you hope to get a chance to read the report in detail. One is about how do we understand the health vulnerability in urban areas. And I think as you can see, it's a complex diagram in that sense, but that is the whole purpose, is in order to trying to actually capture that complexity and decode that complexity, so that we know in terms of how do we, when we are talking about vulnerability, health vulnerability particularly, what does it look like for whom and how do we address it? So 2 points that on this particular diagram that we would like to highlight. One is that when we talk about urban poor, it's certainly not a homogeneous category, and so it's important to understand who are we talking about, what kind of vulnerable groups that we are talking about. Just if you can see the inner circle, those are the different kinds of vulnerable groups that we are talking about. Second is that one cannot possibly talk about health vulnerability unless we are actually also trying to link it to the next set of the factors that you look at, is in terms of even their access to basic provision of, say, safe drinking water, sanitation, the kinds of living conditions, no access to any kinds of social security and entitlements, or even poor access to healthcare. Forget about the greater exposure in terms of whether it's about waste, air pollution, and other things. And these are important because they intersect in many different complex ways to be able to produce this kind of vulnerability that we are talking about for these different groups. And it's important to understand that. And this actually results, because of these kinds of systematic and structural factors that we are talking about, that really results in very systematic disparities that we are talking about in health status of these poor and vulnerable groups, and which is actually reflected across different kinds of health risks that we are talking about and outcomes, beginning with if you look at even life expectancy, something which is an important indicator and a basic indicator of human development that we are talking about. Life expectancy to be kind of lower among the poorest households if you compare them with the richest households in urban areas, to, even when we're talking about prevalence of, say, tuberculosis, even underweight among children, particularly under, 5 age groups that we are talking about. And, along with this, what is witnessing also in terms of the disparities, that there is a growing prevalence of NCDs even among the poorer households. And this is basically from the large data sets that we are talking about, and what it also tells us that we need actually much more nuanced, this kind of disaggregated data for different socio-economic categories within the urban areas. And what do our city reports actually tell us about? Who provides healthcare? What does the system look like in urban areas? How does it address these kinds of health inequalities that we are talking about? Or how is it prepared? Our city reports actually from these 4 different cities and towns um, tell us that the urban health system that we are talking about is far from uniform. The system actually takes different shapes and forms. Even looking at what the National Urban Health Mission actually would look like, they look different in these different cities that we are talking about. What are some of the major challenges that we or concerns that we actually witnessed, across these different cities? One is, and that's a reality of the urban healthcare, is that there are multiple agencies. So that is why it's very, very different from a very clear, simple architecture that we usually witness in rural areas. There are multiple agencies even within what we call, the broadly the government systems, as well as state and non-state providers, and there are parallel authorities even for the same kind of jurisdiction. There are, with the kind of urban areas growing forever, there are overlapping jurisdictions among these different kinds of authorities, and hence, the entire accountability is completely fragmented, and that is one of the important concerns that was evident, across different cities that we're talking about. Second is, even if the 74th constitutional amendment of the Act of 1992, which really talks about strengthening and, it's the role of urban local bodies in healthcare. In overall, it looks that they are less invested in healthcare. Though the pandemic did show some promise, particularly in kind of big cities, what, the kind of leadership role perhaps they could take, and that's one of the kind of lessons to see how can we kind of talk about strengthen, outlining the role of urban local bodies in healthcare in urban areas. Primary healthcare, the way that it is emphasized in the rural areas, it's not something that has been emphasized much in the urban areas, though the National Urban Health Mission, again, has emphasized a lot in trying to strengthen primary healthcare. And, one of the things which is very, very significant is that just the availability of the primary health centers that we are talking about, it just falls short of by the government's own norms by about 40%. And there are very weak referral linkages from the primary to the secondary and the tertiary that we are talking about. Overall, there is a poor community governance mechanisms. And considering that the private and different kinds of private clinics, hospitals that we're talking about, mushrooming everywhere, and hence, there's a higher reliance on private hospitals, resulting in significant financial burden. How does one actually move from this very complex kinds of scenario in terms of the vulnerabilities of different health groups, as well as very chaotic urban health provision and governance structure, if we are really interested in addressing the health inequalities that we are talking about within urban areas? And this is not meant to be an exhaustive list, but I'll quickly kind of share in terms of what the thought process is and how have we thought about these kinds of possible actions that we're talking about. One is that this is not something you were talking about a complex problem. So obviously, you need series of actions. So that is why you can see a long list of actions that we are talking about. The second is that not all actions, need to be can be kind of taken immediately. So some are short term, some are medium term, some are long term. Secondly, actions need to be taken at different levels. So we have tried to kind of think about possible actions at the community level, at the systems level, and perhaps something at the policy level as well. And we also tried to see that who could actually be responsible, and it's not one agency that we are talking about to be responsible for that component of the action. What informs this list of actions? It is informed by actually things which have worked in places. So as you can see in the report in the last chapter that we have spoken about, if we're talking about, say, build community based accountability mechanisms, and we have shown, okay, here is actually an illustration of how the Mahila Arogya Samitis actually works in this particular context. Or even we are talking about, building the capacity of community health workers. How do we look at community health workers actually in urban areas? So this is basically informed by those kinds of things where things have worked. Somewhere it shows promise of actions. Somewhere it's also is that a number of things have been stated, say, for example, in terms of enhancing regulation and oversight of the private sector is something that which is known, but perhaps it's important to reiterate and time to act, now. So that's basically how that we have thought about in terms of the possible actions that we are talking about. And each of these is actually elaborated in detail in the report in the last section. So all that the report is actually trying to say is that this is basically the time that, and it's a call for action for all of us, as researchers, as practitioners, as people working within the government, as donor agencies, perhaps because there's a lot that has to be done, and it has to be done actually now. So that's basically what where I will stop here, and now we can move to the panel discussion, which perhaps would enlighten, and elaborate some of these issues that we are talking about. So I will hand over to my colleague Srilata, and very, very happy to introduce all of you to Srilata. Srilata has been a colleague for several years, and she has worked in the field of public health for close to 3 decades, and has worked on a range of issues concerning health systems, programs, and policies. And her recent work is on nutrition and its impact on well-being, on adults and children, as well as something which is very interesting and pertinent area of work on decentralization, health sector governance that she's talking about. So over to you, Shilata.
Thank you, Arima. Thank you also for that overview of the important findings of our report. Good evening to everyone, and thank you for joining us for this discussion on reimagining urban healthcare. I will start the panel discussion with a very brief introduction to all our panelists, and then we can jump straight into the discussion. Today we have with us Shatarupa Sen Bhattacharya, who is currently the national editor of Citizen Matters. She has over 16 years of editorial and writing experience across a variety of formats. She holds a master's degree in economics from Calcutta University and is a keen observer of social and development initiatives across cities in India. Welcome, Shatarupa. We have also Ravi Duggal. He's a sociologist trained at the University of Bombay. Also holds a postgraduate diploma in business management. He has recently completed his tenure with the International Budget Partnership, coordinating the India Country program. And he's presently an independent researcher and consultant. He's widely published on topics related to health systems financing and governance. Thank you for being here. We have Samir Garg as well, who has worked on public health for more than 2 decades. He's currently the executive director of the State Health Resource Center in Chhattisgarh, and he has been involved in the rollout of urban health programs there since 2012. His work has been focused largely on strengthening of public health systems as a practitioner, a policy advocate, as a researcher as well. Welcome, Samir. We have Carolyn George. She's an experienced physician, epidemiologist, and her work has focused on communicable, non-communicable disease, as well as operations research at the national, state, and grassroots levels. She's currently heading the Community Health Institute of Research and Training, and she's the chair of research in Bangalore's Baptist Hospital. And through their community health division, she has co-designed several health interventions at the community level. Thank you for being here, Carol. And last, we have Rajiv Sadanandan. He's the CEO of Health Systems Transformation Platform, a think tank on health policy and systems. Among other state and central government roles, Rajiv has worked as Health Secretary of Kerala and has been the CEO of the RSBY. He's also been a member of technical committees set up by UNAIDS and WHO, and is currently one of the commissioners on the Lancet Global Health Commission on financing primary healthcare. So happy to have all of you here. And I will start the discussion with a question to Shatarupa. And in our report, what we found was that the one of the main things we did was to unpack this whole concept or this whole category of urban poor. And what we found is that it's dynamic, it's multi-layered, and it's intersectional. And the health risks that are faced by the urban poor are often far more crucial than those faced by the rural poor in some ways. I was wondering, your byline is very intriguing. You say life is just a set of stories. So, in the stories that you have encountered over the past so many years, have you found that your work resonates with this finding of ours? And could you expand a little bit on what those stories tell us about urban health and well-being?
Thank you very much, Srilata. I hope the audio is clear enough for everyone to hear. Thank you for inviting me to be a part of this session, and a very big thank you to Azim Premji University for unveiling this very important report at such a critical juncture in our nation's journey towards public health. You are right, Srilata. It is extremely, in a way, it is reinforcing and at the same time concerning that so many of the findings that were shared by Professor Mishra while she was presenting the report actually resonate very closely with the stories that we do at Citizen Matters. So for those of you who don't know, Citizen Matters is, to put it very briefly, a platform where we try to bring together journalism and data, citizen voices, expert inputs all together with a view to making urban life or our cities more resilient and sustainable, and very importantly, more inclusive. So public health, and specifically the inequities in urban public health, how they affect the urban poor disproportionately, that is a very strong focus of our editorial as well. And to briefly summarize what our stories, especially over the last 2 years, when the pandemic has created unprecedented situations in the sector for everybody, for all players and stakeholders, there are one or two very strong trends that we note, which I would like to talk about today. And these are all trends that we have witnessed through our stories, commonalities in the stories that we do from Bangalore or Chennai or Delhi, Mumbai, everywhere, all the cities that we are present in. So the first thing, talking about the disproportionate impact of health burden on the urban poor, I think one factor that needs to be highlighted here is that health cannot, although most commonly when we talk about public health, we talk about the health infrastructure, the systems, the primary health care available in urban centers. But it is actually also a function of what is happening in various other domains. Okay, and those linkages are extremely important to note if we are to reduce the burden on the urban poor. So policy making in each of these domains has to be integrated with the concerns that we usually see when we report from the ground. So the environment health linkage is, of course, one of the more commonly discussed ones. But just to take an example, I would like to bring in the example of education. We have seen in the past 2 years, every marginalized or low-income urban community, telling us how huge an impact the closure of schools has had on the nutrition and health of the children in the family. You know, because that one midday meal that they get from the school actually takes a big load off the parents. You know, some of them are ration card holders, but what they get through the PDS is just not enough to, to complete the nutrition of the child or to give the child the nutritional benefits required. So, with the closure of schools, this has come into focus. But even if schools reopen today, I think it has huge implications for policy making in the education sector, about enrollment, about auditing the efficacy of the RTE Act that we have. So similarly, if we look at environment, of course, we talk only about air pollution, but there's a lot, and especially around this time of the year, air pollution in Delhi is our core focus. But even if we go to local pockets in other cities, let's say where the fisher folk, in northern Chennai, who live in the in and or around the Ennore industrial cluster, for them, it is a constant struggle because of the not just the air pollution but also the water pollution from the thermal power plants. Okay. uh, People have told us constantly about how their children suffer and how low their access to healthcare is, how the kind of problems that they face is not always cannot always be met at the primary healthcare center. So they have to travel to a hospital which is some distance away, and that costs them rupees. So one mother has told us that, every time I have to take my child for a checkup for the problems that are resulting from the pollution here, it costs me 500 rupees. Where do I get that? With the kind of earnings that we have. So, yes, so the one thing that I feel very strongly about is that health cannot be viewed in isolation. Public health is not something that we can view in isolation, and it is extremely important to bring in the other policymakers and other domains and have a kind of integrated approach to it. Secondly, the second point I'd like to make here is that even when we talk about the urban poor, and this is something which even Professor Mishra has spoken about, and I think even you mentioned briefly, Srilata, even when we speak about the urban poor, it is not a homogeneous section that we are talking about, and their concerns are not always the same, right? So if we are looking at particular communities, each of them has its own concerns. So once again, just to take an example, we spoke to an organization that works with transgender persons in Mumbai, and they told us that for the community, for members of the transgender community, one of the huge issues is affordability of the kind of medicines they need, which may be related to HIV treatment or some kind of hormonal therapy they need. So affordability is a huge issue because of the pricing of these medicines. Secondly, they just tend to put away institutional care for as long as they can because they are very fearful and wary of being bullied or stigmatized in some way. So they will not go to the healthcare center or the hospital till the situation is really serious. And of course, like identity proof is something which we've seen already with COVID registration. One of the reasons that so few among the transgender community have been vaccinated is because most of them don't have valid ID proofs. And so while this has come into focus, while we have been giving COVID registrations, but the fact is that they stay out of the net of many other social welfare and health schemes because of this problem. So what I'm trying to say is that every community has certain specific concerns. Talk to waste workers and they will talk about the lack of protective gear that they get from from the municipality, or about the lack of generally, the information and communication campaigns that can teach people about the importance of segregating biomedical waste, especially in a situation like COVID. So every section has its own concerns, which is not always addressed by the public or the blanket public health net that we talk about. So I will just stop there for now, and I can come back and maybe answer any questions that are there.
Shatrupa, thank you so much, because what you've really done is lead us very nicely to the next question by showing, by explaining and describing the complexity of this whole idea of urban poverty. But what we found was, while unpacking urban poverty and vulnerability was hard, even defining the concept of urban was in itself kind of took some trouble. And what I'd like to ask Ravi is, the NUHM, as Arima also pointed out, has already been around for some years now. And the impact of that program has been mixed, I think, uneven, definitely. And part of it perhaps is because of the multiplicity of providers, part of it is perhaps because of overlapping jurisdictions and so on. But if we really want to establish health as a public good, especially in urban areas, do you think the NUHM is an adequate tool, or can we reimagine it in some way?
Okay, thanks, Srilata. Uh, I think the problem with NUHM is that it's a defective design. It was kind of a cut-paste job from the NRHM, which had been rolled out much earlier, and NUHM was kind of piggybacked onto that. But then urban areas are fairly different, and the kind of history that urban healthcare systems have was very different, and that probably was not acknowledged within the NUHM design. Because if you look at a typical town or even a large city, uh, uh, this concept of primary health centers was not there initially. I mean, it came much later. It came in with World Bank support through the establishment of health posts, say under the India Population Projects, and later on through other health systems reform projects. Uh, so I think it's the vulnerabilities that you were talking about. I mean, Arima talked about in her presentations. These are all functions of the structure that we have. This is the structure of the system, the healthcare delivery system that we have. And for example, I mean, just to give you a contrast, I mean, government employees, central government employees, and members of parliament get excellent and free healthcare through the CGHS system. Why can't the common citizen get the same? I mean, it's a question of equity. I mean, if you're talking about health as a public good, and you want to get rid of all vulnerabilities, you want to create equity. So equity can only happen when you actually build a universal access healthcare system. So on through the CGHS, the government spends, which is taxpayers' money, our money. They spend around 10,000 rupees per capita per year. Whereas for the Aam Aadmi, the common citizen, your health ministry's budget, state and center combined, is around 1,700-1,800 rupees per capita. So that's the wide gap. And that kind of comes in your face as discrimination that we see. So it's the healthcare system design, which I think, so we need to move towards a healthcare system which is uh, kind of a comprehensive primary healthcare basis. And see, there's a huge divide that we see in rural and urban healthcare systems. Rural areas have what you call primary health centers and sub centers, where the focus is largely on preventive and promotive care. Unfortunately, the curative component in rural areas is very weak, and therefore people have to go to quacks and other private doctors to access curative care. In the urban areas, it's the other way around. Urban areas, healthcare systems, even the public health systems, are completely curative oriented. So you may have dispensaries if in a particular state, or worse still, all primary care is dealt with in public hospitals. Now, public hospitals are for referral care, for higher levels of care, and even a large teaching hospital like in Mumbai, you have a JJ hospital or KEM hospital. 70% of patients which come there come for primary care. Now, that's a huge burden on a hospitals whose resources are meant for higher levels of care. So specialists are seeing cough, cold, fever, which should actually be seen in the primary healthcare system. And then, so primary healthcare has to become the gatekeeper for higher levels of care. So we need to create a system like the NHS in UK or many other countries have their different kinds of healthcare systems. So unless we do that, they're going to face all these problems that you've identified in your report, whether they are governance issues or vulnerability issues or equity issues. So I think that's what we uh, are looking at. And at the root of all this is the budget. I mean, the finances or the resources that are made available to the public health system. Now, even a health policy, however bad it may be, it even talks about 2.5% of GDP, which roughly translates to around 4,000 rupees per capita. Okay, that's the kind of minimum resource that we need immediately if you want to deliver, if not to the entire population, at least 80% of the population which does not have this kind of privileged cover that CGHS or defense services or ESIS or other social insurance. So that 20% population does have universal access. 80% population is left on their own. They get some bit of care from the public health system, but I mean, highly under resourced. So, NSS data also tells us that only about 20% of outpatient care is dealt with in the public health system, and about 40% of institutional care, hospitalization care. So I think financing is at the root of all this. So we need to make certain minimum resources available. I just briefly, I mean, I've done a study of urban local body finances, a historical kind of analysis, and with a specific kind of focus on Mumbai, which I've published in EPW just recently in August. Basically, if you look at the history of urban local body financing, I would characterize it as from robust to bust. If you look at the 60s, 70s, and even 80s of urban local body financing, especially healthcare, you'll find that they were urban healthcare services were actually very good, perhaps a little under resourced, but everybody till the 80s was using the public health system in urban areas. Very few actually went to the private. I mean, you may go to a local GP, but hospital care was almost 80, 90% in the public system. I mean, I've been born and brought up in, I'm not born, but I was brought up in Mumbai. And we had an excellent Bombay Municipal Corporation run healthcare system. Up to 80s, it was fine. Everybody went to the local dispensary or to the nearest hospital that we have in the city. And if we needed tertiary care, we went to a teaching hospital, of which there are 4 or 5 in the city. So that was the kind of situation. But what changed the thing, and the same thing happened in education also. What changed was middle class was given an option by their employers to opt for health insurance. Instead of giving you reimbursements or some kind of medical allowance, we will buy insurance for you, we'll pay the premium, and you'll have the freedom to still seek healthcare in the private sector also. That changed the thing because the middle class was the voice of the public health system. And once the middle class moved out, the healthcare, public healthcare system became, especially in the urban area, it became a system for the poor. So it became a poor system. So this is the tragedy with because of underfinancing of healthcare. So we have never crossed 1% or 1.1% of GDP in terms of provision of resources for the public health system, health care system, both in state and central government as well as municipal government spending. But you do see a kind of a change that has happened through the years. So still 60s, 70s, and even 80s, about one third of the municipal municipal budgets was devoted to healthcare. Today, for a city like Mumbai, it's down to 9%. So that's the kind of crunching of resources or taking away of resources for health, and health is no longer a priority. If you want healthcare, go to the private sector. This is the message that the system of healthcare that we have gives you. So, because you go all the way to a public facility, medicines won't be available. And we know that in the out of pocket expenditures, medicines account for 60-65% of the spending. So, I think these are the kind of issues that can only be addressed if you create a robust, organized healthcare system, which becomes a referral system. Create good, comprehensive primary healthcare, and everybody uses it. It has to be a common system. I mean, like we talk of common schooling. So similarly, healthcare has to be the same. Why should parliamentarians and bureaucrats get one system, organized sectors workers get another system, and Aam Janta gets no system? So this is the paradigm that, or the issues that we need to address. I mean, I can give you figures if I have the time of how the municipal finances have been kind of destroyed. And it's probably only Bombay Municipal Corporation which actually functions like a parastate, because it doesn't depend on resources from the state government. But otherwise, all towns and cities, their municipal corporations or municipalities do not actually have much interest in healthcare. It's all done by the state, and the state cannot handle that at the local level. So if the municipal system is good, then it's also greater local accountability and people can question. But the state is far off, the center is far off. So for people to demand accountability. So if you want, I can stop there, or if you want, I could add a lot of detail.
Maybe, yeah, I'm sure there's lots of interesting details behind this, but perhaps we could stop here, because I think the point that you made about having a strong and a robust primary healthcare system in urban areas, which has not been, in fact, the focus perhaps of the NUHM, and certainly hasn't been put in place. And what we found in looking at health systems in urban areas was that, first of all, they are underprovided. I mean, they're in short supply, they're poorly distributed across cities and towns, and it forces even the poorest to seek care in the private sector. So I thought we could move to Samir, because in Chhattisgarh, they have a very interesting they've tried a new system. They've put in place this network of community health workers. And I wonder, Samir, if you could talk a little bit about the Mitanin program in Chhattisgarh, and how, what is the potential for similar programs to actually provide the kind of primary health care that is sadly missing in urban areas?
Thank you, Srilata, and thank you, Azim Premji University, for this opportunity to share my views. The research that Azim Premji University has done is very useful and very timely one, and it prompts our thinking to take up the issues further. So, regarding community processes or community health worker programs, and I also include the Mahila Arogya Samitis as part of that architecture at the community level. So in Chhattisgarh, we have had a positive experience with them, as the report notes that these networks have come up well in the state and they are vibrant. But why they are vibrant and how they can be vibrant in other places, so that needs to be understood. So some of the points have been picked up by the report, like the population norm. So nationally, NUHM talks of about 400 houses per ASHA in an urban slum. So 400 houses, it's even very difficult to remember names of 400 people. So forget about providing services or being in touch with them. So it is too large a population to be looked after by one ASHA. Then the point about Mahila Arogya Samitis being vibrant and Mitanins having good capacity, that relates to their support structure. So in NUHM, one of the errors or gaps I see in terms of when they promote community processes, they have forgotten about the or they have left out the supportive supervision structure that the rural ashas have. In rural areas, for every 20 ashas or so, you have asha facilitators, then their coordinators at the block level and district level. In urban areas, the supportive supervision or a training cadre has not been thought of, or no, it was neglected. So as a result, we find that in many states, the urban part of the asha and as a result, the Mahila Arogya Samitis, they have not come up. So both of them require a strong, supportive structure to come up. Then my worry is about the non-slum areas. So NUHM provides for the slum areas. So do non-slum areas don't need any community participation? What about rest of the urban population? So now we have a huge problem of dengue in every town and city in India, and we find it is largely prevention related work, and then we find that there are no mechanism of community participation amongst the non-poor. uh, my point is, do at least as much as being done for rural areas. Then after methanins, once you have a good set of methanins working at the community level, uh, they won't be effective unless you have a good backup of primary care, curative and providing services. So unless what Ravi was pointing out, that no, you have only big hospitals, you have nothing close to the community, you don't have basically primary care services, whether preventive is totally absent, and curative is also not there close to the people. So in that regard, my proposal is, my suggestion is that we should go for health and wellness centers, as the national health policy has suggested, and as the nationally there is a big rollout of health and wellness centers taking place in the rural areas. In rural areas, for every 5,000 population, basically every sub center is being upgraded, and now we have like 75,000 of them across the country, and the rollout has really taken place. And now those of us who are on the ground can see the change it is bringing, no, in terms of services. So one, it brings services closer to people. Proximity really matters, and that will matter in the urban areas also. And the second is the continuity of care. It's not just a clinic where people are coming for OPD care. It is also, there is a continuity of the care to the households. There is follow up of chronic diseases. No, which is making no, it a more comprehensive concept, the wide ranging services, where it is coming closer to the dream of comprehensive primary health care. So a similar setup needs to be there for urban areas. So when health and wellness centers were launched, nothing was given for the urban areas. For urban areas, the existing urban PHCs were merely redesignated as health and wellness centers, which is no addition to the urban infrastructure. So urban PHCs have been very useful in our experience, and in our studies we have found, but there are not enough of them. So like the Raipur, one of the towns you have studied, so there, no, for around 15 lakh population, there are 15 of them. So one per 1 lakh. So that's simply not enough. And at that level, you cannot have any continuity of care into the community, into the home-based care. So Ashas, Mahila Arogya Samitis, they can be effective only if the primary care system no, exists and is sufficient. So there is wide variety of private care providers in urban areas, but some of them qualified, a lot of them not qualified. Quality is the issue there, but cost is a big issue, as your report has also pointed out. So it is so one finds it difficult to imagine a system how we will bring both private providers under the same umbrella, when they, by nature, by characteristics, they differ so much from the public facilities. The public facilities we need to expand, including ensuring free drugs and free tests there. So I feel the same model of health and wellness centers, it can be continued into the urban areas. So the government should do at least that much for urban areas, what it is already doing for the rural areas.
Thank you, Samir. So, what I'm hearing you say, one of the important things that we also realized is that urban areas are not equated with slums. I mean, in the sense that, of course, one needs to be very concerned about the needs of people, the urban poor, and so on. But there are urban health issues that go beyond that, and how are those being addressed? I think that's a very important issue that you brought up. The second issue that you seem to be pointing to is that let's do at least as much as the NRHM. If you're not going to do anything special or different, at least do as much as you're doing for the NRHM. But our report, when we were looking at the stories in the 4 cities, what we found was that actually the private sector is also not a homogeneous group. There are many different faces to the private sector as well. And to some extent, given how patchy the government system is, the private sector in some spaces can be a safety net. So that brings me to you, Carol, in terms of your work in the communities. Can you talk a little bit about that experience, and also, what are the possibilities for collaborating with the government and for really, making a kind of systemic sort of contribution as we go forward?
Okay. Thank you, Srilata, and thank you for this report. I should say that one of the good things that came out from COVID, if I have to say that, is this coming together and going into details and understanding such an important thing, which was actually everybody was trying to, trying to understand from one person's perspective. But this report has brought, in a very holistic way, the entire picture with multiple, multiple areas. So that's something I just wanted to thank Azim Premji University for bringing it together. So Bangalore Baptist Hospital, we serve one of the largest urban poor settlement in Bangalore for many decades. The vulnerability of this population is enormous, with a population density of 1 lakh persons per square kilometer, with minimal provisions of water, sewage, and waste disposal. And we started our work 25 years ago. And then at that time, it was mainly the leprosy work, because the clusters of leprosy used to be there. Over the time, the leprosy has come down. And then we understood that the city is growing and lot of other needs, in terms of health, they were excluded and they could not go to the mainstream, so they will neglect, as others mentioned. And then we see a lot of people coming with extreme morbidities. That is when we thought we should, and also we developed, bond with the community. So we thought we should actually step up and start primary care clinics. So our approach was also based on the community discussions that we had with the community. And we started small with mobile clinics, going to the time which they said, and to the places they opened their houses, and on the pavements they made places, and we used to sit and see patients. So we started that, and over 2 to 3 years, we understood that the need is much more, because we want to do certain procedures and wanted to address it in more, detailed way. So we thought, let us look for a place in the heart of this poor communities. And now it's a full clinic with multiple specialities, all evolved slowly based on the need of the population. We actually serve around 15,000 patients per year in this population, and our services are not totally free. But if people are very poor, we have made provisions that they can actually get into totally free service. The consultation is just a small user fee, 10 rupees. This is just to bring kind of an ownership, and they feel that it's not a charity, and they can question the services, question the quality, and feel dignified about what that they're purchasing the health. So that is one of the things that but if requires, we have a big tertiary care hospital. So if they require any referrals, we actually have at least 500 to 600 referrals in a year to the main hospitals. Sometimes one ICU bill will come around 3 lakhs, 4 lakhs, whatever. So in that case, we have a particular special patient care coordinator who helps them to navigate through the complex, urban hospital. And also at those points, we would, whatever, if they say they can pay only 1,000 for the 3 lakhs, they'll be paying 1,000. That's it. So that's how we have been, and we have in our hospital in a year around 17 to 18%. We keep this amount for concessions, so 35 to 36 crores we have. So we use these concessions from the money that is generated from the other services. If I look at, we talked about in a policy level and a big systemic level, but I would say the most important thing that urban poor or the system that we build should have trust. Because urban poor experience exclusion, not only in health, in everywhere, and they have limited understanding. If somebody comes with fever or whatever, they don't have the agency to go to the internet or to understand, to read books or something. So when they come, to a health center, first of all, they don't come to, because again, they already experience multiple exclusion and things like that. So they try to not to come to step into these, what you say, uncharted territories, but sometimes they have to come, right? So it's important that we build systems that are, structures which are embody trust, respect, empathy. So the exclusion that they otherwise feel, they should be, they should feel included. So that is something which I would say. And also, when we had conducted some of the surveys and when we talked to people, so what they said, the most important, we thought when we give concession, that's what people value most. But most times, and almost 99% of them said, the first thing that they value is we got respect. And there was the doctor explaining to the patient, even though we don't understand even many of the things, but the doctor was explaining their medical conditions to the patients, and also asking them multiple options and trying different things, that including in the consultation. So that was the most important thing they felt valued in our hospital. And in other places, we just say, okay, they don't even touch us, they don't even ask what we have. They say, okay, this is your medication, just give it, that's it. So the involvement, and that involves a lot of builds trust. Then and another thing that I think earlier speakers have told about is the hospital or the health entity that we are trying to bring should always be rooted in the community also. So there should be community conversations. The people who are serving in as doctors or the health team or whoever it is should always also have opportunities to walk to their houses, and understand that and build relationship. So that is very, very crucial, because some of the things that we think is medically to cure and things may be totally nonsensical, or certain things won't work in their setting. So it's very important for us also to get into these communities and to understand and give solutions which is practical for them. That's the trust. The second thing I would say is to think health in two ways. One is to approach urban health in a systemic way, that is 1 unit for 5,000 or whatever, with metrics, and it operates at a population level. The other dimension is to think in a very personal level, because at an individual level, wellness and illness is very, very personal. So there should be a motivated health team delivering patient-centric care from the heart. That is very, very crucial. Otherwise, we can just make things, structures and things like that, but people have to feel welcomed and to be, be trusted, so that they can, they avail these, whatever services that we are building. Now, another thing that I would say is I have to talk about the providers. We have to also think about the incentives in the ecosystem for the providers. It's a constrained clinical setting, the ventilation, everything will be constrained. It may be a very infectious environment. There's limited professional growth or poor literacy of the population. So it may not be sometimes very pleasant. So there should be respect in any system, whether it is government or private or whatever system there is, the people who serve these conditions, there should be respect for their services, and also there should be an opportunity to grow. So that is another important consideration that look. And in terms of, you talked about working together with the government. So what we have done is it's more complementary. In our places, there is a primary health center. They're very good in terms of services related to maternal and child care. So we refer our patients to them and say, you go there, you get all whatever it is required from the government system. But there is a problem in terms of, if there is a high risk obstetric care, the system is not good. So we take up that and they refer to us, and then we take through our system, and difficult obstetric care that we take it. So that is one way we work in terms of complementary. They also ask for multiple trainings, which we are able to do. But sometimes when we write referrals to a government system, one another thing is they are in this maze, especially tertiary care system, in a place where they can't understand, nobody understands them. There is no information where, when is the doctor coming, where I have to stand in the queue for how many hours, and at the end when I turn, I say, oh, today's token is finished. In that whole system, they are, it's not treated, they are not treated kindly, and they feel it's better to just, whatever happens, it's okay, but I'm not understanding how long, how many times I should go, and I don't know whether I'll get anything from it. So that kind of they get lost in the big system. So that is a thing that we feel when we write. Like if we have a cancer center, if we write for chemotherapy there, I know that they're just going to take a decision. They go there, come back after 2 visits, they decide, no, it's okay to die with cancer, but I can't figure out the system. So that is something, but we have to actually, government is the biggest stakeholder, and we all can only do little, but it is important that government take multiple stakeholders, the community, the multiple providers, the community health organizations, everybody together, and the people there, and then have conversations, and also based on the strength build system which are people centric, both for community, both for the community there, and and also for the providers. And long term, I should say, the urban poor should move from only the demand side to the supply side. Then it is their own system, they will improve it, and I would feel that would be a good way. We have to invest in education and making them into maybe nursing and doctors, and then I feel many of the issues may get solved in the long term. I think that's from my side.
Thank you, Carol. Very much rooted in your experience, and this issue of trust and respect, I think, is so critical, especially when it comes to government health services. So thank you for raising those 2 points. I would like to wrap this up by turning to Rajiv and talking about some of the recommendations that we've made in the report at different levels, at the community level, at the systems level, at the policy level, and so on. You've had a very wide-ranging experience, Rajiv, at state level, national level, international level, and so on. And I was wondering if you could comment on those recommendations and also share some of the learnings that you have had in all these different settings where you have played a role.
Thank you, Srilata, and thank you to the organizers for inviting me here. This report is extremely timely because, as many of you know, the 15th Finance Commission has recommended devolution of a large amount of money to the urban local governments for improving health system. And those of you who have been involved with would know the total amount of confusion that is there at government level, what to do with it, because the recommendation is on infrastructure. And we know that more than 60% of the investment in health comes not from infrastructure, but from HR. And where is HR going to come from? So it's a major issue. And when we started looking at the urban primary care, especially, we found that while it's okay to criticize what exists, there's very little clarity on what is it that will work, and we are still trying to figure it out. So it was with a lot of expectation that I read this report, and because because you're calling it as a call to action, the expectation from this report for being pragmatic and implementable is very high. It's not an academic report. You're positioning it as a call to action. So I hope you won't mind if I complain that I find this report is too differential to the mindset that was involved in designing the NUHM. Now, as Ravi mentioned, what was done was the rural one was copy pasted onto the urban system. Now, that just won't work, because the situation in the rural area is different from what is there in the urban area. For example, in a rural area, in a PHC, as a PHC medical officer or as an ANM, I know where my people are there. I know they're tagged to a location, they're tagged to a social milieu, and they're reasonably well fixed for me. So if I do ANC, I know that this lady would be there, in this location. Maximum what would happen is that she would go to her home for the delivery and so on. So that's kind of clearly defined. There's a tuberculosis patient who is on DOTS. I know that this is where he stays. I know these are his friends, etc., etc. So the milieu in which an efficient rural primary healthcare provider works is very different from an urban situation. Throughout this discussion, I had this feeling that the urban area is in some way badly off. That is not borne by the data. If you look at urban, even if you look at government, the supply side is oriented more towards urban side than the rural, and so I get slightly worried when there's a hint that we should actually be we should actually be focusing on the urban area, perfectly justified, but not at the expense of the rural areas, which continue to be badly served. Now, one of the mindset that one of the reasons that we invested in remote rural areas and in building hospitals was that there was a supply constraint. In the urban area, the supply constraint does not exist if you recognize that the private sector is also part of our allies. There are adequate number of providers, and most of them have existing relationships with providers. The problem, it has two problems. One is this relationship is entirely limited to curative care because of the financial strain. People are not, or lack of knowledge, people are not willing to invest in preventive and promotive care. Whereas when you look at many international health systems, private providers are contracted not only to provide curative services, but also to provide preventive and promotive services. Can we work with existing general practitioners to add a set of needed services that we think is important to the benefit package? And then in order to remove the financial constraint, government can then purchase this package for the poor. But the problem is going to be, how do we monitor that these services are delivered, and how do you ensure that you have a provided payment mechanism that clearly incentivizes the quality of services that are delivered? I mean, I know it's difficult. I know it is. It needs a lot of information requirement. It's a contracting requirements, etc., etc. But continuing to work with something that has not worked and adding more of it, I think we should recommend that there should be an additional ways of looking at it. Secondly, in this whole discussion, what we have heard is that when we say urban poor, I mean urban healthcare is bad. It's not for the entire urban population. It is for a certain set of people. There are constraints that make a certain segment of the poor more vulnerable to disease, and I think we should move away from this catch-all kind of service provision to segmented service provision. Those of us who work in HIV know that this is how the success was achieved. Initially, we are focusing on generating awareness in the population, etc., etc. But the moment you started working with key populations who are more vulnerable to infection, that is when we started bringing the infections down. So, can we rework the understanding of primary care to focus on the areas that will yield us the best return, which is a segmented population of the vulnerable? Can we redesign things in such a way? The danger would be that if we build a system for everybody, the limited resources would get fragmented. Is it possible to kind of target the services that are being provided? I agree with the report that the financing of urban health is it's underfunded. But somewhere I caught, I hope I'm wrong. Somewhere I caught the suggestion that the urban also has an equal claim to the existing set of resources that are available for health sector. Now, the rural expenditure is highly inadequate. Unless we divide some mechanism to firewall the rural expenditure, no matter what the claims is, I still believe the rural population is worse off than the rural poor is worse off than even the poor in the urban area. And the report does not have any evidence to contradict that. The report is comparing the differential between the urban rich and the urban poor. But when you compare the rural poor with the urban poor, the differentials are not much. And when you include the access cost of the rural poor, remember, even if there is public facility available in an urban center, the poor has an access cost, transportation, accommodation, wages foregone, which the urban poor does not have. So in the bargain, it is still the rural poor that is being badly served. So be very careful about creating a kind of demand on the resource that is available to the rural area, because the political power is still with the urban sector. That brings me to the discussion of community mobilization. Now, in the 74th Amendment, what we tried to do was to move the primary care, the public health, to the municipal agents. What is the justification for that? Because as was rightly mentioned, there are lots of other determinants of health which are outside the purview of the health department. Housing, sanitation, all these come together at the local body. So if the local body owns up health also, it becomes possible to channelize this service to bring it together so as to ensure, so as to provide improved health. Now, I missed this any reference to the political setup in the urban areas. After all, urban local governments are run by elected politicians. If I rate the municipalities of the urban local bodies of Gujarat and Maharashtra to be doing better than other local bodies, because it is linked to the political setup. And political accountability is practically the only accountability that we have, where we can hold people accountable. Bureaucrats are hardly ever responsible. So hardly held accountable. So when we discuss community mobilization, while the report is very eloquent on the involvement of NGOs, I think the role of political leadership also has to be highlighted, because unless health becomes politically salient, it's not going to get the importance that it needs. Now, the advantage that is there in an urban area is in a rural area is the traceability of data. For example, every subcenter has a family health register which is supposed to track the health needs of the aged, the children, etc., etc. Now, that kind of a manual register will not work in urban areas, and fortunately, thanks to technology, that is not needed also. And maybe it's time to think about leapfrogging that traceability of data and with technology. We're looking towards the future. If the digital health mission ever takes off, and which has this unique health ID for individuals and for institutions. And using the unique health ID, if you can tag the data longitudinally, an electronic health record can be built up. Many of the constraints of mobility and and houseless populations, there may be a possibility of taking care of it. So I think this report, I think we should also need to look at the possibility that technology allows us to reimagine the provision of primary care in urban areas. I hope I've generated enough controversy for us to lead to a healthy discussion. Thank you.
Thank you, Rajiv, for having lived up to all our expectations and certainly thrown up some very, very interesting ideas, which I think we do need to take note of and see how we can sort of address them in hopefully further work, because this report is really, I would say, it's a beginning rather than a culmination. We are hoping to continue our engagement with, looking at urban health issues in multiple different ways. And many of these points will be very important in our future deliberations. So thank you for that. Now we want to have a really, really quick second round of questions, but this is going to be rather focused, and we want, if everyone could just spend really quick 1-2 minutes, talking about if you had to pick one recommendation for the way forward in terms of urban health care and improving, urban healthcare as we go forward, what would it be? So I'll go back to the same order, go back to Shatarupa, and what would your one key recommendation be?
Thank you, Srilata, and thank you to all the other panelists. There were so many really interesting and fascinating points that came up in the discussion. But just for the sake of time, I'm not, just to stick to your question, Srilata. I think in the end of it, there are two things. I'm sorry, there's just not one recommendation, but there are two things that I would like to point out. One is the empowerment of the urban local, or rather, the finances that the urban local bodies should have. And also not just finances, I think capacity building is also a huge issue within the urban local bodies to bring together all the programs in a way that bolsters the public health. We have this, I don't know whether it's national character or what, but we have seen from our stories that everything seems to work in silos. So at one level, we need to bring together the various social welfare benefits and schemes at one point. And I think the best place to do that is at the urban local body level, because they are the ones who should be commanding the finances and the administrative power to roll out these schemes and to ensure that they reach, the last person in the chain. So that is one thing. The other thing that I want to very quickly touch upon, which was not raised in this, is that it was Caroline's. I must thank Caroline, because it was her points that led me to this, that brought this back to me. And that is, I still think we do not attach the kind of attention or give the space that mental health requires in our public health discourse. And this is especially while we have heard a lot about mental health during the COVID period. But when we go down to the grassroots level, we realize that again has a lot of nuances, and it is much more difficult for the, for communities at the grassroots level to access the services. And we need, when we talk about primary healthcare centers, or whether we talk about health and wellness centers, I think mental health, capacity building in mental health services is going to be extremely critical in the years to come.
Thank you.
So I'll just stop there.
Yeah, sorry, I interrupted you. Were you done?
Yes. I said I'll just stop there and we can come back.
I think mental health is a critical issue as well, and especially when talking about trust and also stigma, and so
Yes.
partly one has to address capacity building, but one has to also address these issues of how do you get people
Social
to trust the
conditioning.
system enough to
Yes.
approach. Ravi, you go next. You're muted, Ravi. I'm sorry. Yes.
Sorry. Yeah, I was saying that I've already, in a way, kind of suggested what needs to be done, like basically benchmarking a minimum level of resource, like 2.5% of GDP or 4,000 rupees per capita or whatever to begin with, and so you have to make those resources available so that you can, or the human resource deficiency which is there, or other supplies which are not available in a timely manner, etc., can be addressed, and that we can create that health and wellness center, primary healthcare base on which we build the healthcare system through a referral kind of system, and so that it's a universal access approach. So I think that is what basically needs to be done, and maybe what I'll do is I'll take the two India route and uh, make my final point. I would say that I come from an India where our bureaucrats and members of parliament get excellent and free healthcare from the taxes we pay via the CGHS. But the ordinary citizens of India have to struggle to access even the poor quality of public and private health care services, and with a huge burden of out of pocket expenditures. And I would like to live in an India where such discrimination in access to healthcare does not exist. So that's my kind of closing punchline.
That's
And it's
brilliant,
related
Ravi.
to all the issues that I have raised in terms of creating equity, getting rid of vulnerabilities, etc. Financing has to be a strong base and development of a healthcare system, uh, like an NHS kind of thing, or whatever is would work in India. I mean, we need to work seriously, and health has to become a political issue. Otherwise, we will never change it. Otherwise, we'll just work in these pockets of silos, etc., of different programs, and that is what has been, uh, you can say, what has destroyed our developing a healthcare system in this country, working in silos and creating a segmented kind of approach. Thank you.
Thanks, Ravi. I hope you don't get the same backlash that poor old Veer Das got.
We are anyway regarded as seditious people, so it's okay. We are on the scanner.
Sameer?
Uh, yeah. So I'll no, so there is no evidence to say that purchasing from for-profit private sector in urban areas is going to work so far. So it already exists in case of inpatient care through the various insurance schemes that have existed for more than a decade now in various no in almost all states in different schemes. So there is no such evidence which shows that it will work. So there is a huge diverse private sector that exists in urban areas, but that no, that does not mean that it will work to partner with it. Non-profits are a very different, very different part of private sector, and I would even call them public, no, public sector by their motivation. And my recommendation then remains the same, that to expand the government primary care services, both curative and preventive, in urban areas through a mechanism like the health and wellness centers, and to expand the community processes also and strengthen them by providing them supportive supervision structures.
Thank you. I think you've even earlier made that point that having supportive supervision is a critical part of making urban health systems more efficient and equitable. Uh, Carol, would you like
Yes.
to go next?
Yeah, I actually want to first make a comment to Rajiv's one of the comments saying that the urban and rural thing. So we work in both urban and rural areas. And during COVID, what we saw is in the first 3 months of first infection, when we did the zero survey, the urban area was 58%. It was the infection rate was, zero prevalence was 58%. Same time we looked in the rural area, it was only 8%. Now, in terms of both had lockdown, no food and things like that. So urban area, they all go to daily wages, they have no food. Whereas in rural areas, they also have all the airport, everything closed down, they didn't have work, but they had small area where they actually started putting ragi or whatever it is. There is a space where they grow and they could just get minimum, not a nutritious meal or anything, something to eat. They were able to, or they had a cow, so they milked, and children were getting something. Whereas in rural area, they were just in terms of going begging, even trafficking, there were instances in which like 500 rupees children were sold human. You can think about all the social evils, all these things were happening. Now, if you look at it, of course, rural area, in the second wave came, of course, rural area also got affected, and the people came to the urban areas because there were no tertiary care centers there. They had to come to the urban area. But relatively, they had more time, they had some sustenance, and at the same time, I would say space, the sheer fact that people staying in such close proximities, in such small spaces with a lot of waste and things, and the things, it causes an enormous health risk and difficulties for even anybody to. So I wouldn't say one is better or one different vulnerabilities. And looking at the way the urban population, urban poor is growing, I would say still, it's a good case to look at the urban poor. And it's a comment, from Raji's point of the vulnerability part. Okay, so the overall thing, what I would say is the recommendation. One is we always come up with great policies and things like that, very structural way and on top way, but when this policy comes into common man's houses and things like that, that's where the whole problem is. So whatever we come up with, I would say that it should at least, go to the grassroots and see whether it works, or have it in small places and try it works. It has lot of health is an area where contextual things matters a lot. India is a country, every 50 kilometers you go, you have a different food, different language, everything. So contextual thing is also very important. So I would say there are frameworks but also come up with things which works in the granular level and try to learn from each other. And maybe we will not come up with the same framework, but it should have ability to come up with contextualized thing. That autonomy has to be there, that decentralization. That's my recommendation.
Thanks, Carol. Very, very relevant. And last word to Rajiv before we go on to the Q&A section. So please, Rajiv.
I have no option but to respond to Caroline's comment. One is that the COVID is a different situation altogether, unnecessarily brought about, could have been handled much better. So one of the problems I struggle with in many of the discussions, not only here, even international fora, is everyone is obsessed with COVID. Yes, but remember, those who did well on COVID were precisely those people who had invested in health before. So getting COVID focused at this point may not be the right way to go. One. Two, I'm not saying that urban health need not get invested. Yes, we do need investment. My worry, as someone who has handled health system for a long time, is that because the political power of the urban lobby, it's quite likely that even more resources will get dragged away from the rural areas. And that is a discourse that I don't want Azim Premji to be held responsible for. No? So the report to be held responsible for. That's a joke. Okay. Now, again, the grand designs are fabulous. But what I have seen is that unless we sign up to deliverables, specific deliverables, they don't go anywhere. Now, if a corporation has got its vulnerable population, slum population, homeless, whatever, mapped out, and they assure that, and they are able to ensure that we will achieve these kind of health outcomes for them, I think that would be a good starting point. For example, we'll screen all our slum dwellers for, let's say, tuberculosis or for leprosy, and ensure that they complete treatment. So those kind of specific deliverables. I know Ravi cautioned about too much of segmentation. Unfortunately, I'm trained as a bureaucrat to work on segments and get specific results. But my experience is asking people to do general things without setting specific objectives to be achieved for a defined population finally ends up not getting much done. Thank you.
Thank you, Rajiv. That's excellent advice, I think, to set achievable targets. Now we will move on to the Q&A part. There are lots and lots of questions I can see in the chat box. Could I request Arima and okay, the questions are coming up on the screen. I wonder if you all can read what's on the screen, or I can read it out as well. There's a question to Ravi specifically, requesting him to suggest whether any aspects of the NUHM plan is worth considering for the future.
Well, I mean, I don't think NUHM has any plan or strategy there. I mean, it's been revised so many times, and it's not really taken off. So it's highly under-resourced. The kind of resources needed to set up primary healthcare system in urban areas have not been allocated. A complete rethink is required. I mean, we need to rethink. I think the basic model should be the health and wellness center concept. Upgrading the existing primary healthcare system using that is a good idea. It needs to be kind of fleshed out much more, but that's a good basic idea, and we need to build on that. And I think that should be common to both rural and urban healthcare systems. But ultimately, you have to place it in the context of the ground reality, because it is very different. Histories are different. Urban areas have a very different environment. Outreach is much more difficult in urban areas, unlike in rural areas where there's a defined space in which paramedics can engage with. That's not possible in an urban setting, though there may be a lot of high density population, but numbers are huge. As Samir said, I mean, 50,000 population for a sub-center is, I mean, it's ridiculous. I mean, a paramedic cannot handle that. So we need to look at the context of the given scenario in which we want to place a healthcare system. So,
thank you, Ravi. Okay, to both Ravi and to Rajiv, government organizations are now turning to innovative finance for fulfilling health gaps. How effective do you think they are in providing health services and infrastructure? Ravi, could you go first, and then Rajiv next?
yeah, I don't know. This innovative financing. I mean, generally, Niti Aayog means insurance, and I think it's something we need to say no to. I mean, we need to develop a tax-based model, a social insurance model. We need to strengthen something like ESIS and increase the base of social insurance in this country, so that my sense is easily 60% of the workforce can be covered, and the balance 40% the government can pay for them in a social insurance framework. And then we need to use tax-based funds. We should not go the insurance route, because for government today, innovative financing means insurance, and I find that problematic. We have not achieved much. Yes, to some extent, the very poor, the BPL, who are covered by that, some of their expenses, especially for hospitalization, have been taken care of. Whoever has been able to access that benefit, but we know there's a lot of discrimination happening there also, on the basis of caste, on the basis of your location. Because I mean, how will an insurance-based model seeking care in the private sector work in the northeastern states, where there's hardly a private sector, for example? or in the rural and tribal areas of the country. Where do they need to go to the state capital to seek healthcare using the insurance model? So I think these are and insurance doesn't work for you lifetime. I mean, once you can't afford to pay the premium, especially if you are going to contribute to insurance like the middle classes, you stop earning once you're a senior citizen. You can't afford insurance. I mean, I can't afford insurance after my retirement because insurance wants for a 5 lakh cover, they want something like 45,000 for me and my spouse. So that's the kind of resources. Where would I get that? And so I think insurance is not likely. It's not worked anywhere in the world. I mean, in the US, 30 million people don't have access to healthcare or are underinsured. So why will it work in India, which is a completely disorganized kind of things where often insurance is also taken for a ride?
Rajiv?
I think there is some misunderstanding. If government can fund NHS and provide NHS, none of us would argue with it. But this beard has become grey waiting for it, and Ravi, yours has become even whiter waiting for it. And
Yes,
hardly,
yes.
unlikely, we'll see it during our time. Okay. So then, and secondly, innovative financing does not mean insurance. It can mean purchase by government from providers. That is also possible. Some areas it has worked, Turkey and so on, it's worked. The problem is that we've been waiting for the best, and it has not happened. And frankly, 2.5 is not enough because Kerala spends about 7,000 rupees per capita. That's not enough. That's not enough. So the question is, even the purchase is not privately funded. For the poor, it has to be tax funded. The question is, does government provide or does government finance? That is the question I was referring to. I mean, there is no way that the people can pay adequately for needed healthcare. I mean, at least the people who don't have regular employment. So nobody would recommend for
I certainly agree with you. Government has to be the main financer. That is how it happens the world over.
Exactly. Exactly.
It's
So the
almost
problem is
monopolistic
that,
financing.
yeah, the problem is that when NUHM argues that in Estonia you can buy it from the private, but in India you can't, I have my problems. Why can't we buy from Caroline's hospital? What is stopping us? She mentioned about having to charge people. Why should she be able to ask to charge? Why can't we pay for it?
I agree. Yeah.
Okay. We have a question on what are the recommended ways for convergence with programs which address determinants of the health of the urban poor, such as WASH, women and child development, labor. Shatrupa, do you want to take a shot at that? Because you did mention about, how there's so much of intersectorality.
Exactly. And I think this is one of the greatest challenges that we have seen at the local levels in the communities that we have spoken to is, as I already mentioned, that a lot of the schemes and other welfare programs that are floated work in silos, and there is no they don't, as the question also mentions, there's no convergence. Now, how that it is to be done, once again, it goes back to the recommendation that I had made when I was speaking about not just empowering or not just devolving finances to the urban local body, but also sort of building a capacity either at the health department level, also at the primary health delivery level, whether it's the health and wellness center or whether it's the primary health care center. So there has to be a nodal agency, or I don't think we need a separate nodal agency, but there has to be a kind of coordination between the various agencies that exist. And that requires a certain kind of capacity building and a certain kind of approach. So, to answer the question, I think it just goes back to what I had said at the recommendation level, that we need to we need to empower our local bodies both with finances and with capacity.
Sorry.
I'm sorry. Yeah. So I was just talking about, empowering our local bodies, both with finances and with the kind of capacity needed to deliver programs. A lot of the times, it is the implementation which suffers. It is the implementation which we see has, the plans are great on paper, but when it comes to reaching the person who needs it, it fails. And unless we have a certain kind of capacity within the teams that deliver these schemes, we are not going to be able to achieve that.
Thank you. We are kind of running out of time, but we have time for one last question. And this is we might need to understand community mobilization differently in urban. Do USHAs enjoy trust and familiarity like ASHAs? Very unlikely. How do we change this? How does USHA belong in urban community? I think this, if Samir and Carol could quickly respond to this, I think that would nicely round out our discussion.
Yeah, Srilata, USHA is slightly outdated terminology. I think in some documents they had written urban ASHAs as USHA, but ASHA is the term being used thereafter. So I see no reason why ASHA in an urban area cannot enjoy the trust of the community. So urban communities are also communities. There are additional challenges. There will be no greater amount of migration, people coming in, going out, new slums being created, old slums being demolished. So you need more flexible programs. You need programs that if a new slum comes up, you are able to add to the number of ashas. So, but there is no reason why a asha cannot build trust. Enjoy the trust of the community in an urban area. So, so it is feasible, but you cannot enjoy trust of 400 households if they are given to. So, what we had discussed before, the population norms need to be different, and they need to be supported better.
Yeah, I agree with Samir. But I would say that the role of ashas are more or maybe equally important. The difference between urban community and rural community is urban community, again, like in any of they are like, even though they stay together, they don't know each other, and fragmentation is part of urban life, and everybody minds their business, even in the very poor community. So even like in a rural area, if there is an abuse or anything, somebody else, the next door people come and say, you can't beat your wife. Whereas in urban area, nothing happens. You do, okay, it's not my business. That's how. So there is a very little cohesion in the urban communities because of these kind of migrations and things. So what my point is, the ashas would be an important glue or something which actually going to stick these things together and make trust and also cohesion in the community. So their things are very valuable. Maybe the numbers, yes, but I would say if you have to go and cover 100 households in a rural area, you may have to walk 3-4 kilometers, whereas in one gully in 200 meters your 400 households are there. So that is the difference. In 1 kilometer we see here around 1 lakh population. In rural areas it's not same, so that is the difference. But I'm sure it would be different in different. So based on what is workable in the reality, we may have to change the norms. Yes.
I
Srilata, may
think
I add something?
yes, please do.
Yeah, actually, there's a good model of community-based accountability where communities get mobilized and demand accountability from in Maharashtra, and it's there in about 18 districts. It's mostly in rural areas. They're trying out in urban areas also. It's called community-based monitoring and planning, and it is run through a nodal NGO, and then there are in each block and district there are NGOs. It's through a network of that, fairly well established, funded by NRHM. Okay, and so it's part it's part of the NRHM accountability budget, and with that coming in place, actually the healthcare system has improved substantially. 4 to 5 times of footfall increase in the use of the public health system. There's huge demand from below. So medicines are not available immediately. An SMS goes out. It floods the district health officer's phone with messages: this medicine not available, that available, and they have to respond. So I think it's a good system. which is working. The present government is trying to, the central government is trying to kind of sideline it, but I think that's a good model established, which can be extended to urban areas also, and they're experimenting in urban areas also in some cities.
That's wonderful. Thank you so much. We started off hoping for an interesting and insightful discussion. I think we certainly exceeded all expectations of that. So many, areas, topics that have been covered, all the way from financing, governance, down to community level mechanisms, to trust and respect. All the, I think, most critical issues that are, important for our own understanding of health systems, and particularly urban health systems. Thank you so much for being here, for sharing your thoughts, and for giving us the time. Thank you very much.
Thank you. Bye.
Thank you.
Thank you. Bye.
Bye-bye.